Hello students, today I'm talking about oxygen saturations, level of consciousness and also pain and the assessment of pain. Oxygen saturations, when we're thinking about the background information, this is an estimation of the arterial oxygen saturation of hemoglobin on each red blood cell. This is measured as a percentage and there's different pathologies that can happen, that people can function adequately on a low oxygen saturation over a long period of time. If you're a smoker, you will accommodate to that difference. But for the normal range, it is 95 to 100% of oxygen. And so what happens is this small red diode sits over your finger, and the light that goes through your finger is looking at those red blood cells and looking at the hemoglobin and whether or not what percentage is tied up with oxygen. So that's why it can be a very useful number to notice if it's between 95 and 100 as normal, or less than 95, and we might be thinking about what we could do as a nursing intervention. So this might be sitting someone up, it might be increasing their oxygen or commencing them on oxygen via nasal prongs or a mask, or it might be doing something like chest physio. Take some deep breaths and coughing exercises to notice what's going on. The person isn't taking enough oxygen into their lungs. So it is non-invasive, meaning that it doesn't have to go into the body. You need to put it on a fingertip. Sometimes it can be put on toes or ears, but they're the most common areas on your fingertip. And yes, it also means that we can titrate our oxygen. So say someone has oxygen on the nasal prongs going at 3 litres per minute, but we notice that the oxygen saturations have stayed at 94 and have not improved. So we might need to increase the amount of oxygen that they're breathing in via those nasal prongs. It is always indicated when people might have low oxygen status. So if someone is on a medication that is keeping them sedated and not breathing deeply, or if someone has had a heart attack or that myocardial infarction there, or if they have a respiratory illness and they have oxygen going to support their respiratory function and their gas exchange. So that's oxygen saturation, and you're going to be able to practice that in the sim labs. We are now talking about consciousness and level of consciousness. Sometimes this is referred to in writing as level of sedation. So if someone has been sedated. This should be initially assessed every time you see someone in a general survey and also throughout the vital signs assessment. And as it says in front of us, deterioration can signal a medical emergency and has to be addressed immediately. Different level of consciousness can be measured in different scale. This is the AVPU scale. It's a pretty, it doesn't go very well together as an acronym, but you can never forget it. So what we're looking for is A, being alert and orientated. Someone is responding to a verbal stimuli. Someone is only responding to pain, or someone is unresponsive. So AVPU, that's what I'm looking for. So if I need to do a trapezius squeeze onto someone's shoulder for them to open their eyes and react to me, that would get a P, that would on the AVPU scale. What is normal is that someone is alert and orientated, and also that someone is responding to verbal stimuli, because it might be that someone is just sleeping or resting with their eyes closed, and if I was to say, Barry, are you awake? And your eyes were open, that would be still quite normal, wouldn't it? Now I'm going to cover pain. So pain is often called the 5th vital sign. Pain is unpleasant sensory and emotional experience, and this can be associated with actual or potential tissue damage. So that's something to consider in our definition. Another way to look at pain is that pain is whatever the person who's experiencing that pain says it is, because pain is subjective, and so pain needs to be addressed and cared for, and pain is exactly what the person says it is. So to judge someone else's pain is very poor nursing practice. What does this mean? It means that because pain is subjective, it can be difficult to assess. Some people who are in a lot of pain move around a lot, and some people who are in a lot of pain don't move at all. So when we're looking for behavioural cues to work out whether someone's in a lot of pain or not, it isn't very helpful. And of course, in nursing care, we can provide medication as a nursing intervention to deal with this pain, or perhaps we can provide hot packs or cold packs or massage or lots of other things like distraction therapy and getting family members on the phone or whatever the person would like to have for the pain that they're experiencing. But the most important thing to say is that there's a lot of people who are in our nursing care who are in pain unnecessarily. And it might be because they haven't told you about their experience of pain, or it could be that you don't think that the pain is presenting as it should, or what you expect a person to do when they're in pain. Different factors that influence pain. It can be age. So years ago, it was considered that babies actually didn't feel pain, but of course they do. They cry. We know that if babies have pain over a long period of time that isn't addressed, this can also end up with long-term impacts. So it impacts with poor weight gain or learning deficits in later life. Older people also feel pain. So sometimes people will say, oh, because they're an older person, of course they're going to have pain because they're old. And that's really not good enough, is it? Because we have medication and interventions that we can provide to help our patients. Gender can make a difference. So societal expectations, hormonal issues, and even just the genetic makeup of people can mean that they have a different experience of pain. Culture can also shape our experience of pain, whether you're expected to have pain or whether you're allowed to verbalize the pain in different elements of culture. Meaning of pain can also mean something, so people might think that pain is a punishment for something that they have done, or a spiritual pain. So that's the manifestation of that. Anxiety, so stress and worry can magnify pain. So maybe you've had the experience of this too, that when you're worried about something and you knock your little finger or you bang your elbow against the door and instantly it's like, oh, this is the worst thing that's ever happened to me, because you're already feeling in a nervous state. When you're tired, a similar thing can happen. Pain beliefs can also impact this. Family and social support can make a difference as well. People, if they feel isolated or feel well supported, can make a difference in their experience of pain. And acute versus chronic illness. So someone who's acutely unwell and in pain compared to someone who's had pain for a long period of time can really make a difference about that subjective nature of pain. So we do, as a nurse, need to take time to evaluate all aspects of pain, and we have some tools to assist. This one is the pain score, and this gives a numerical rating scale. So 0 being no pain and 10 being the most you can imagine, where are you sitting right now? That can be useful to work out what we should do and how we should act for this pain. We also have the Wong-Baker Faces Scale, and there's more detail in your online module about this one. And this is the idea that we can look at faces, and someone who might not be verbal or might be very young can point to how they're feeling. So that can impact that as well. We also have another score called the Functional Activity Score, and we're looking at, is your activity severely limited by pain, moderately, or not limited by pain at all? And this Functional Activity Scale score is on the back of your QADS form, so that you can check with your patient if the pain is limiting that activity. We also have more detail about the PQRST mnemonic, and this is very useful for any different kinds of pain. So because we know that pain is so subjective, we're trying to gather more data. So P is what provokes this pain or what palliates the pain. So what started the pain and what would stop the pain. That's under P. Q, what's the quality of the pain? So is it stabbing, burning, itching? What does it feel like? What's the quality of the pain you're asking about there? The region or radiation is, where is the pain starting and where does it go to? So is it that it's moved from one place to the other, or is it going out from that area? Where is that pain? The severity scale is from 0 to 10. The idea of where, if 0 is no pain and 10 is the most you can imagine, where are you sitting right now? Then we have timing. So when did the pain start and when did the pain stop? So that's an interesting one there too, isn't it? About how long has this pain been going on? and you is understanding. What do you think this pain is about? What do you think is happening with this pain? So that understanding can be important because from research they know that if a patient has feelings of impending doom, that is actually a red flag for something really terrible going on. If a patient has an understanding that the pain is life-threatening, don't negate that. Don't say everything's going to be okay, because you just don't know if it is. It's much better to say you're in the right place, I'm helping you, we're doing everything we can, and gathering more data there. So that's the PQRST-U mnemonic, and hopefully that's helpful. I've been talking about pain today, so hopefully when you come into the sim lab, we're going to be practicing the Wong-Baker Faces Scale and building upon this from the general survey. So thank you very much, students.